right, I think we'll go ahead and get started. My name is Christian Bergman. This is the VCU Department of Internal Medicine Grand Rounds. Today, we are joined by Dr. Bozkurt from down at Baylor, down in Houston College. And so we're also joined by Dr. Greg Hundley, who's the chair of the Division of Cardiology, for a discussion today on COVID myocarditis, myocardial injury, and the COVID-19 mRNA vaccine-related myocarditis. I'm going to start with just a couple of housekeeping issues, introduce our speaker, and then turn it over. So just a reminder for everybody, for the internal medicine residents, it's chili cook-off on Saturday. So at Dr. Barrett's and Dr. Call's house, 4 p.m. on Saturday. Another quick thing, we are still in a virtual environment. We encourage questions. You can utilize the chat, the Q&A feature, or raise your hand, and we will unmute you at the end to be able to have an interactive back and forth. Last thing, if you need technical assistance, you can message either myself or Thomas Bryan during the talk, and we will get you situated. The CME code and the New Innovations QR code will be live at the end of the chat as well, and we can put the CME code in the chat box now for those seeking credit. So without further ado, let me introduce Dr. Bozkurt. Dr. Bozkurt is the advanced heart failure and cardiac transplantation specialist at Baylor College of Medicine in Houston, Texas. She is also the Associate Provost of Faculty Affairs and Senior Associate Dean of Faculty Development. She's also the Marion Gore Chair of the Department of Medicine at Baylor College. She serves as a Senior Associate Editor for Circulation, a heart failure section editor for the Journal of American College of Cardiology, and is the co-chair of the 2020 AHA-ACC Heart Failure Guidelines Writing Committee. She recently served as the past president of the Heart Failure Society of America and led the Universal Definition and Classification of Heart Failure. Throughout her career, she's been recognized as excellence in clinical care, education, and leadership. She's been the recipient of numerous awards, including the American College of Cardiology, Proctor Harvey MD Young Teacher Award in 2005, the Gifted Education Award in 2016, as well as she's received presidential awards in education and Master Clinician Awards at Baylor College of Medicine. She's also listed as one of the world's highly cited researchers in Clarivate, top 1% of Web Science researchers. Lastly, Dr. Bozkurt actively participates in clinical and translational research. She presents at national and international science sessions, teaches medical students, residents, fellows at the bedside and in the classroom. She also mentors trainees and faculty members. Dr. Bozkurt, we are delighted to have you here today. Dr. Hundley, thank you for joining us. We appreciate and look forward to your talk. Thank you.
Dr. Bergman, thank you for that humbling, gracious introduction, and to Dr. Hundley for inviting me. I'm going to try to provide a perspective of where we are related to COVID-19 infection-related cardiovascular problems versus vaccine-related myocarditis, which has been recognized and has been covered in case reports and recently in some high-impact publications, including in Journal of Medicine. What I will do during this presentation, these are my disclosures, I'm going to try to provide you some numbers. I usually don't like providing that many numbers, but I do recognize that in the media, as well as in the general population, there is an interest in figuring out what exactly is the risk related to the COVID vaccination. So the first part of my talk is going to be about the vaccine-related myocarditis. In the second half, I'm going to talk about the COVID-19 infection. And I'll try to provide a perspective of the magnitude of risk, the benefit of the vaccinations against the risk, as well as the mechanisms implied for both vaccine-related myocarditis as well as COVID-19 infection-related cardiovascular problems. So in terms of the myocarditis, in the general population, this number is quoted a lot. Myocarditis is diagnosed in approximately 10 to 20 individuals per 100,000 individuals per year. It's been historically recognized more often amongst males, especially younger males, compared to females. Post-vaccination myocarditis is a rare adverse event and has been historically reported following smallpox vaccination, influenza, even hepatitis B or other vaccinations. In the pre-COVID era, among 600,000 reports filed in the VAERS reporting system in CDC over the last 18 years, myopericarditis was identified in 0.1%. And approximately 80% of these myocarditis cases, and these are including all former vaccinations, approximately 80% of these myopericarditis cases post-vaccinations were among males. In the pivotal efficacy and safety trials with the COVID-19 mRNA vaccinations, the Pfizer and the Moderna, there were no reports of myocarditis. There were reports of systemic reactions that were mild and transient, but interestingly more common amongst younger population, more often after the second dose as expected. And the adverse cardiovascular effects in these trials were very isolated, very rare, but they didn't entail myocarditis. The early reports of post-vaccine related myocarditis came from Israel. And this came out in approximately June with the media releases. And Israel, the Ministry of Health reported 148 cases of myocarditis amongst 10 million or more than 10 million vaccination doses administered in Israel. And as you recall, the predominant vaccination in Israel is with Pfizer vaccine, which is an mRNA vaccine. Majority of the cases were following the second dose among men, and majority were amongst ages between 16 and 30, with the highest risk being between the ages of 15 and 19. They quoted the prevalence, and I'm going to start, trying to create the commonality of these numbers that are being reported. Though they're reflected in different denominators, I'm going to try to give you the perspective on the common denominator of the 100 per 100,000 individuals. So they reported approximately in the general population, 1 case out of 100,000 being vaccinated. And amongst the high risk group of ages 16 to 30, that risk was about 1 in 20,000. Most of these cases, though were hospitalized as required for a myocarditis diagnosis in Israel, resolved with very minimal supportive therapies, and all patients, majority of the patients were discharged in 4 days. These were followed by Department of Defense in the US reporting 23 cases in the military of myocarditis following approximately 2.8 million COVID-19 vaccinations in the military health system, majority of which were mRNA vaccines. This again equated to approximately 1 in 100,000 individuals being vaccinated. These were followed by case reports and case series, again, predominantly in young male adults or adolescents. And after these reports, in June, the CDC Advisory Committee on Immunization Practices convened and started reviewing the VAERS, their passive as well as their active surveillance data in all their databases, and concluded that the benefits of the COVID-19 vaccination clearly outweighed the risks of myocarditis after vaccination. With these reports, both the case reports, case series, and the CDC's data analysis, our team convened a review, and we published this in circulation in August. The data analysis we performed were preceding data that was reported by CDC in June, along with the 61 case reports that were published to date before this publication. Of the 61 case reports, majority of the presentations, this was a very common theme, and you're going to see this repeatedly in the subsequent publications, majority presented with chest pain at day 2 after the second dose. And some had fever and constitutional symptoms and myalgia the first day after the vaccination, but most had the chest pain the second day. These were predominantly young males, and the case reports were mostly from hospitalized individuals, hospitalized for mild symptoms, but because they were recognized to have myocarditis, they were admitted to telemetry and or to step down in a variety of different locations. And most of these individuals were hospitalized. None were hemodynamically unstable. None of them had prior comorbidities or prior history of COVID-19 infection. And individuals actually were tested negative for the current COVID-19 or other virus antibodies, including hepatitis and or Coxsackie, and majority had spike in their antibody levels for SARS-CoV-2, reflecting effective immunization. Almost all had elevated cardiac troponin, the highest level of which reached a peak 3 days post-vaccination and then declined throughout the hospitalization. And natriuretic peptide levels, when measured, were elevated in approximately 2/3 of the patients when measured. CRP levels, interestingly, were elevated in most when measured and decreased along with cardiac troponin. And EKG was abnormal with ST elevations in majority of the patients. And echocardiogram was abnormal in only 40%, with only a few demonstrating a decline in LV ejection fraction on presentation. CMR was abnormal in all when used as a diagnostic modality with late gadolinium enhancement as well as T1 or T2 imaging changes. All patients in those case reports had resolution of their symptoms and signs and their diagnostic markers, including their troponin levels and imaging findings when retested. And these actually were very convincing that the myocarditis presentation was mild and was not associated with major adverse outcomes. We also provided a summary of the CDC's advisory committee's analysis, which actually examined all the data in their vaccine adverse event reporting system, which is their passive reporting system, the VAERS system, as well as their active surveillance system, which is called the Vaccine Safety Data Link. The crude rates of myocarditis and pericarditis cases by CDC by VAERS database were highest amongst the younger males between the ages of 12 to 17 and was quoted about 67 cases per million second doses, equating to approximately, again, 7 cases per 100,000 doses. With ICD-10 codes being used in the active surveillance database for hospitalized patients, the rates were lower and approximately 26 cases per million doses for males between the ages of 12 to 29, again, equating to approximately 2 to 3 cases per 100,000. So the risk appeared to be somewhere between 2 to 3 per 100,000 to maybe 7 to 10 per 100,000. And as seen on this slide, the working definition for the CDC is quite important for us to keep in mind because the definitions and the confirmation of the cases matter. The CDC's definition for probable myocarditis includes patient symptoms accompanied with one or more findings of either troponin elevation or abnormal EKG or cardiac MRI. Confirmed, on the other hand, is symptoms accompanied with biopsy findings, which of course is not done in majority of the patients, or symptoms accompanied with troponin and MRI. So troponin MRI along with symptoms is a confirmed definition in CDC. Of course, it's important to examine the risk of myocarditis in the context of the background risk with what's happening with the COVID-19 infection. And this slide tries to represent that, and this is an adaptation from the CDC data. The COVID-19 infection risk is on the right side, and the vaccine-related risk is on the left side. Even for the focus group of ages between 12 to 17, as can be seen, the COVID-19 infection-related risk with hospitalizations, with ICU admissions, even with death for ages 12 to 7, far exceeds the numbers of myocarditis cases. This is for 1 million second dose of COVID-19 administered. So let's say 50 to 60 per million. That would be about 5 to 6 or 5 to 7 per 100,000 myocarditis. And those cases are mild compared to, for ages 12 to 17, 215 hospitalizations, 71 ICU admissions, and approximately 1 to 2 deaths. And this figure represents the COVID infection-related hospitalization rates on the left side, plotted on the right side with the COVID-19 vaccine-related myocarditis risk in numbers. And the hospitalization rates were based on COVID-19 hospitalization active surveillance network that the CDC has. And these rates are as of May 22nd. As can be seen, the hospitalization burden is quite high for each age group compared to the mild myocarditis cases as represented on the right side. Subsequent reports by CDC in August confirmed that there were no fatalities in the US related to vaccination-related myocarditis. There were in August, by August 30th, 2,500 cases of myocarditis reported for over 330 million doses of mRNA vaccines in the US. The risk of myocarditis was approximately 18 to 20 per million doses for individuals receiving the vaccine between the ages of 18 to 24, and the risk decreased with age. Interestingly, in July, European Union reported 5 deaths related to myocarditis following mRNA vaccines. But interestingly, all these 5 cases were elderly and had comorbidities. And this was in the context of 200 million vaccines, mRNA vaccines being administered in Europe. There was a report from the New Zealand Ministry of Health of a death, a single death, following COVID Pfizer vaccine administration attributed to myocarditis in a woman. There were no other reports from New Zealand, but that was a single case. In September, we had a very important publication from Israel reporting the safety of the vaccine in the context of the COVID-19 infection in real-world population. This study reported integrated data from the largest healthcare organization in Israel, and put the perspective of safety of the vaccine against risk related to vaccine among 880,000 vaccinated individuals over age 16 in Israel. In this cohort, there were 21 cases of myocarditis in the vaccinated group. The median age was 25 years and 90% were males. Vaccination was associated with an elevated risk of myocarditis compared to the unvaccinated. The risk ratio, the multiplicative risk ratio, was 3.2, and the risk difference, subtraction, was 2.7 events for 100,000 persons. But it was clear that when compared to the infection-related complications, and that's shown in orange. And now we're looking at the myocarditis risk with the infection itself, the SARS-CoV-2 infection, as you can see on the right side, and also with the yellow bars in the lower part, the myocarditis risk is markedly higher with the infection itself. The risk ratio is 18, and the risk difference per 100,000 persons is 11 with the infection. The risk ratio is 3, and the risk difference for 100,000 people is about 2 to 3. So excess risk of myocarditis would be 3 per 100,000 persons vaccinated, and 11 events with SARS-CoV-2 infection. There's also evidence from this real-world data that the risk of other cardiovascular complications are significantly higher, as seen on this slide. The yellow bars and the arrows represent the risk related to the infection itself. As you can see, deep venous thrombosis, pulmonary embolus, intracranial hemorrhage risk is, as well as the myocarditis risk, is markedly higher with the infection itself, the SARS-CoV-2 infection, compared to vaccination. Regarding the risk of myocarditis with COVID-19 infection in the US, in September, CDC provided a report that was very important about the risk of myocarditis with the infection, with the COVID-19 infection, especially clarifying what's the risk of myocarditis for age under 16. As you can see, for age under 16, the risk of myocarditis, by the CDC definition, which is very strict, was 37-fold higher among patients who had the COVID-19 infection compared to not infected. The overall myocarditis risk infection risk with COVID-19 infection was 16-fold higher. So this actually put the perspective also in the US that the myocarditis risk is markedly higher with the infection itself than with the vaccination. There were a variety of publications that created a lot of social media uproar, providing, I think, a misinterpretation of publicly available vaccine adverse event reporting system data. VAERS data is a passive reporting, and a group published their data analysis, categorizing everybody with chest pain and or troponin I elevation as myocarditis. And they could not capture all the hospitalizations because they didn't have an active surveillance system. So they relied in their community records of what they perceived as were the community hospitalization rates. And thus, the numerator was very much accentuated and the denominator was shrunk. And therefore, they reported in not a peer-reviewed fashion, a report that came and leaked into the social media of their rates being higher than the CDC's reported rates. But even so, their reported rate was only a few fold higher. We're not talking about 100-fold higher or 1,000-fold higher. Even in these methodology invalid studies, the risks were not markedly higher. And quite a few of these studies actually were withdrawn by the authors themselves when they recognized, for example, they made a 20 to 30-fold mistake in their vaccination rates when the public health providers, this is from Canada, provided them the true number of vaccination rates, which is important for the denominator. And thus, the social media had a lot of erroneous reporting of how publicly available passive reporting systems are to be used. I want to provide this slide. The vaccine adverse event reporting is an early warning system. It's passive reporting. Thus, it can provide a signal, but is inadequate to provide data to determine the magnitude of risk and or a certain causality. CDC usually has a process. It ascertains the association using active surveillance systems. They have a variety of programs represented in the lower panel inside that bracket that they, upon the risks that they notice from VAERS, they immediately commission these questions to these health networks that look at in an active manner of all hospitalizations, all cases. And then with that data, CDC provides the analytical reporting of the magnitude of risk. And again, most of the data that I had already presented was with the analysis of both the passive as well as the active data that has been analyzed by CDC. Recent reports from large population cohorts, such as the Kaiser Permanente with over 2 million vaccinated individuals, including ethnically and racially diverse populations confirmed, supported the initial reports of CDC. Actually, the reports from Kaiser were even lower than the CDC rates and did not reflect, interestingly, and I think reassuringly, any disparities for race and ethnicity for myocarditis following mRNA vaccination. There were also large-scale national reports coming from Israel that were published in New England Journal of Medicine that actually confirmed these rates. And as you can see, the incidence ratio compared to historical data for risk of myocarditis, even for the age group of interest for ages between 16 and 19, were increased compared to the historical rates, but the rate ratio compared to unvaccinated was about 8 to 9. Interestingly, from this New England Journal of Medicine paper that got published last month, one case that was hospitalized and was fatal. And that actually created a concern whether there were potentially cases that may have an adverse outcome. The age of this individual is not reported, but is not in amongst the youngest population. There was a second report that came out in New England Journal of Medicine at the same time, reporting again national data of all myocarditis cases amongst 2.5 million vaccinated individuals over age 16 with 54 cases of myocarditis. And interestingly, one case was associated with cardiogenic shock, and with a follow-up of approximately 83 days, one patient died from an unknown cause after discharge. Incidence of myocarditis per 100,000 persons being vaccinated with at least one dose was quoted as 2 in the general population and 10 for males aged between 16 and 29. So let's examine potential mechanisms hypothesized to be implicated for mRNA COVID vaccine-related myocarditis. This, I think, is a moving or an evolving discussion. There are suspicions for molecular mimicry between the spike protein and self-antigens. Antibodies against SARS-CoV-2 spike glycoproteins have been experimentally shown to cross-react with structurally similar human peptide protein sequences, including alpha-myosin. And this regulated immune response is definitely suspected as a cause and possibly resulting in a polyclonal beta cell expansion, potentially an increase in the frequency of natural killer cells. And interestingly, there is definitely a concern for autoantibody formation against cardiac proteins, and that is implicated as a potential cause. Though so far in a case report, when autoantibodies were checked, though there were antibodies detected, these were not necessarily found to be the specific antibodies known to be associated with myocarditis or cardiomyopathies. Immunogenicity of RNA creating an immune reaction has been entertained as a potential mechanism. We need to keep in mind that in the general population, we don't see such a fervent response. And the RNA vaccines have been modified in the nucleocapsid to reduce the body's innate immune response. And in majority of the public, we do not see a fervent response, a augmented increased inflammatory response to the level of not allowing the RNA to be translated, because such an immune response would abrogate the ability of the mRNA to be translated. We know that the body is able to allow the mRNA to be translated because the antibodies to spike protein are able to be produced. Testosterone is definitely a concern, especially due to the puberty age and the male predominance is creating a concern whether testosterone is playing a role, both in historical perspective, the male predominance in all myocarditis cases, as well as in experimental models, testosterone being implicated to play a role in committing the body's immune response to more inflammatory nature towards a Th1 type immune response is thought to play a role, especially for the age and the male dominance. Mechanisms that are thought not to be implicated include SARS-CoV-2 breakthrough infection, because none of these individuals did have evidence of SARS-CoV-2 by PCR, or concomitant or other infection with other viruses, such as Coxsackie or adenovirus. In a few cases where the DCM genetic panel was checked, there was no evidence of these individuals having pre-existing antibodies and or pre-existing genetic profile of DCM. And most of these individuals were ANA or motility factor negative. The pattern of presentation is not also suggestive of hypersensitivity. These individuals did not have rise in eosinophils. And in the few cases where there were biopsies obtained, there was no evidence of eosinophilic myocarditis. And none of the adjuvants or the lipid nanoparticles used have been associated with myocarditis either. Delayed hypersensitivity reaction or serum sickness type of presentation has not been seen with the myocarditis cases. Contrary to the adenovirus vector, Johnson & Johnson viruses, thrombosis or thrombocytopenia or TTP-like presentation or antiplatelet antibodies were not reported in these cases. And also antibody-dependent enhancement of immunity, which is usually seen with re-exposure to the virus or with a breakthrough virus, characterized by non-neutralizing antibodies generated by the past vaccination or infection, failing to shut down with re-exposure was not able to be demonstrated because none of these patients had any evidence of breakthrough infection. Thus, these currently are probably ruled out as potential mechanisms. In terms of the cardiac biopsy findings, when obtained in only a few cases, did not demonstrate evidence of fulminant myocarditis or lymphocytic myocarditis or myonecrosis. These could be due to sampling errors or different mechanisms, or that these may not be the classical lymphocytic myocarditis that we're used to seeing with other viruses. And current approaches to how to recognize and manage, if presentation with chest pain, of course, especially in the younger population, it would be possibly advisable for individuals to have an evaluation with cardiac enzymes on EKG and in perhaps a consideration of cardiology consultation, and along with that consideration for imaging for those individuals with maybe the abnormal findings on EKG or cardiac troponin. Most of the case reports most of the investigators in the case reports provided information that they treated these cases with NSAIDs or colchicine. Some were treated with steroids, very few with IV immunoglobulins. Some were not even treated and resolved on their own. And again, in the US case reports, none were hemodynamically unstable, except for the European cases that I mentioned. There were no evidence of cardiogenic shock requiring advanced therapies. The questions that remain are, if myocarditis with the first dose, what to do? Most of the clinicians agree that maybe delaying the second dose or completion with a non-mRNA vaccine may be an opportunity for those individuals that have a confirmed diagnosis of myocarditis with the first dose. The risk of myocarditis in the 5 to 11 year group with the recent data that has been reviewed by FDA and CDC is quite assuring that the benefits outweigh the risk. Safety data from the trials, which included 3,000 children who received a vaccine, did not report any myocarditis. The reactions from the clinical trials were mostly mild or moderate, and there were no serious adverse events related to vaccine, including myocarditis. And if testosterone is playing a role, and this is just a hypothesis on my part, probably the risk of myocarditis would be likely less at younger ages before puberty, but this is just a hypothesis. Now I'm going to focus on the COVID-19 infection involvement and what do we know about the myocardial involvement with COVID-19. I'm going to start with the pre-COVID-19, with what did the viruses do to the heart before COVID-19. In the pre-COVID era, the common infectious etiologies for myocarditis included a variety of pathogens, including viruses such as adenoviruses, Coxsackie, enteroviruses, HIV, and the coronavirus causing cold. But coronaviruses, the ones that were implicated in cold, were not commonly identified as causing myocarditis. The pathogenesis of myocarditis in the pre-COVID era was characterized in 3 phases: acute phase of viral entry, activation of innate immune response within a week, and the second phase of activation of acquired immune response with cytokine and chemokine release, and finally either recovery or fibrosis and remodeling in the heart. And natural history varied. It was unpredictable. 12% of sudden cardiac death, and we're talking now about infection, viral infection-related myocarditis. 12% of sudden cardiac death, and we're talking about historical rates, in young adults had been attributed to myocarditis. And among patients with severe LV dysfunction after viral myocarditis, half recovered, quarter had chronic LV dysfunction, a quarter proceeded with advanced therapies such as transplant. And then the arrhythmia risk also was unpredictable. Among patients with active myocarditis, the ventricular tachyarrhythmias could be reported up to 7 to all the way to 47% of the serious. And late gadolinium enhancement could be detected in almost half of these individuals. And the long-term effects were seen as heart failure in approximately 6 to 8% of the individuals. And diagnosis in the pre-COVID era relied on either pathology or imaging. And I'm going to first represent the pathology data, which relied on histological and immunohistochemical criteria of Dallas criteria and abnormal immunohistochemical data for patients who had biopsy. And subsequently CMR findings, which were termed as a Lake-Lewis criteria, identifying presence of edema, late gadolinium enhancement, as well as some other T1 imaging abnormalities. And these characterizations started being used more and more commonly for confirming the diagnosis of myocarditis in the pre-COVID era. Former coronavirus infections and the heart, historically, the simple upper respiratory tract infection causing coronaviruses have not been commonly associated with myocardial damage. SARS-CoV-1 infected more than 8,000 individuals without significant evidence of myocarditis, but in one autopsy series, SARS-CoV-1 was PCR detectable in about 35% of the hearts. But none of the hearts demonstrated lymphocytic myocarditis. MERS-CoV infected more than 2,000 individuals, and one case report of CMR diagnosis of MERS-CoV related myocarditis have been reported. Now let's look at what does COVID-19 do to the heart. A variety of abnormalities ranging from myocardial injury to cardiomyopathy, to shock, to thromboembolic complications. And we do have a range of diagnoses we utilize, including acute coronary syndrome, STEMI, non-STEMI, arrhythmias, heart failure, cardiogenic shock, and thromboembolic complications. And the underlying mechanisms implicated vary. The common denominators include myocardial injury detected by cardiac enzymes, and the attributable etiology includes entities such as cytokine storm, dysregulated immune response, microvascular, endothelial, and thrombotic injury, and of course, in the context of increased myocardial demand due to infection, hypoxemia, and direct infection of the cardiac myocytes. And injury was detected very early on from the initial early reports from Wuhan. 27% of the hospitalized patients had elevated cardiac troponin. And these were initially described as being higher in amongst individuals who were older with comorbidities, and these were associated with increased mortality. Interestingly, the rise in the enzymes were actually quite prognostic for crashing and burning patients, especially if the levels consistently rose, along with other inflammatory biomarkers, which were seen usually after admission. And amongst those individuals who steadily demonstrated a rise in their inflammatory markers and cardiac enzymes, the outcomes were quite bad. And if we examine what percentage of the patients with COVID infection have evidence of cardiac injury, the troponin I positivity ranged from 12% among patients without known cardiovascular disease to 50% of the people who died to 22% of the patients in the ICU. In comparison, prevalence of troponin I positivity in non-COVID related acute viral infections like just flu is about 1%. So if we examine cardiac involvement by other modalities such as imaging, this was a cohort of echocardiography for all hospitalized patients demonstrating an abnormality found in 68% of patients hospitalized with COVID. This data was from Israel. And of course, there were concerns about sudden cardiac death or cardiac arrest with COVID. These were recognized with adverse trends with rises in out-of-hospital cardiac arrest during COVID-19 in Italy and other places. 78% of these were attributable to COVID, some of which could be non-cardiac or due to lack of access or misattribution to COVID. We also recognize that there is definitely a overlap with the MISC, multisystem inflammatory syndrome in children as well as adults, and the rates of the multisystem inflammatory syndrome is steadily increasing both in adults and in children since COVID. And post-COVID, cardiac involvement in the chronic phase also creates a huge burden in cardiology, along with the general symptoms of fatigue, muscle weakness, anxiety, depression, cognitive dysfunction. Some patients describe palpitations, postural orthostatic tachycardia syndrome beyond 4 weeks. And there has been abnormal imaging findings, especially with cardiac MRI in patients who recovered from COVID. In a study that gained a lot of attention, Putman and colleagues reported that amongst 100 patients who recovered from COVID, a large percentage, and I don't want to quote the percentage because this study was criticized for not having a control group, a large percentage had cardiac abnormality and troponin elevation by approximately 70 days post-COVID. These were followed with reports of abnormal cardiac MR findings at varying percentage rates. In this study, 15% of the college athletes who recovered from COVID. Again, these studies were critiqued for not having a control group and created a lot of controversy about what COVID does to the heart. And then were followed by subsequent studies with controls that showed the abnormality rate was lower when compared to the former studies that didn't have a control group, but still were higher than the general population. So in this study, 3% of the athletes had evidence of myocarditis by MRI 22 days post-COVID. These abnormalities were present despite the individuals being asymptomatic, having normal EKG, normal troponin and echocardiograms, and having this subclinical evidence of injury in 3%. And the rates were even lower, 1.4% among student athletes when modified cardiac MRI criteria were used. And these raise the approach of troponin testing, EKG and echo and or cardiac MRI screening for return to play after a positive COVID-19 test results among athletes. And in this study, those with abnormal screening test results were referred for additional testing, including CMR or stress echocardiography. And only with this approach, only 0.6% were restricted to return to sports, and none had cardiac events after testing positive among professional athletes. And similarly, American Academy of Pediatrics provided a guidance on exercise, sports, and physical activity after COVID infection for gradual resumption of physical activity or competitive sports. But most of these are expert opinions, and I think dynamically changing as more data is accumulated. Mechanisms of how SARS-CoV-2 impacts the heart. We at the beginning had characterization of the clinical representation fitting the classical picture of clinical myocarditis. Most of these patients had concomitant bad lung infection, severe hemodynamic instability, diffuse LV dysfunction, EFs in the 20s, and evidence of elevated cardiac enzymes, and were thus named as myocarditis. And yes, there was evidence of SARS-CoV-2 in the heart. The heart did reflect RNA copies when examined, not at the high scale as the lungs did, but it was there. But when we started looking at the autopsy and biopsy findings, the cardiac tissue did not look chewed up. It didn't look like it was infiltrated with lymphocytes that we expect in fulminant myocarditis. The ultrastructure looked actually preserved. There were few interstitial mononuclear inflammatory infiltrates, but no substantial fulminant damage. And there was clinical evidence of severe myocarditis, but pathological studies demonstrated low-level inflammation. And in these electron microscopy, interestingly, SARS-CoV-2 was being found in the interstitium or subendothelium or in the pericytes, but not inside the cardiac myocytes. Thus, there was a question whether there was injury to the endothelium, injury to the microvasculature, which then created the injury and loss of cardiac function, rather than, even though we know that SARS-CoV-2 can infect the cardiac myocytes because the receptors are expressed, the ACE2 receptors are expressed, but it looks like the vessels are affected predominantly and early. And there is evidence of thrombosis and microangiopathy in small vessels and capillaries all throughout the body. And again, all autopsy studies and biopsies currently have the concordance of not showing large confluent area of myonecrosis, histopathology showing only individual scattered cell myocyte necrosis, not lymphocyte predominant. And in situ hybridization, showing virus presence in interstitial cells within the cardiac tissue, and no evidence of, again, myocarditis by Dallas criteria. And that raises the question of there is myocardial injury, but not histological evidence of classic definition. Maybe there is macrophage dominant abnormality in the myocardial involvement, as well as endothelial and microvasculature involvement that may play a role in the cardiac dysfunction. Regardless of the acuity of the presentation being related to COVID, COVID positivity plays a role in all cardiovascular diagnoses. in our procedures and treatment of the other disease entities. So currently, yes, in addition to the treatment of the COVID-19 infection, we also need to treat cardiovascular presentations with COVID-19. We also need to continue treating underlying cardiovascular disease with individuals with pre-existing cardiovascular disease, be it CAD, hypertension, or heart failure when they have COVID-19. And we need to monitor, screen, and also develop perhaps a follow-up strategy. And these are all evolving as we develop more data. So in summary, COVID mRNA vaccines are associated with an increased but small risk of myocarditis, especially in young males. The benefits outweigh the risks of vaccination in all age groups with the data published to date. COVID mRNA vaccine-related myocarditis is usually self-limited and mild. Symptoms usually resolve within 4 to 5 days. The presentations commonly include chest pain, accompanied with EKG abnormality and cardiac troponin elevation, and when imaged with CMR abnormality. Management can vary depending on symptoms. Most of the case reports were managed very conservatively, and the symptoms resolved regardless of the treatment used. COVID-19 infection itself is associated with a variety of cardiovascular abnormalities, ranging from myocardial injury to all the way to cardiogenic shock. Cardiac injuries present in a large proportion of patients who are hospitalized with moderate to severe disease and is associated with mortality. Post-COVID cardiac abnormalities are detectable all the way up to 2 to 3 months, even amongst asymptomatic individuals, probably amongst 1 to 2%. Etiology of cardiac injury is not clear. Despite localization of COVID-19 to the myocardium, the classic lymphocytic myocarditis is not commonly seen. Inflammation, cytokine surge, microvascular thrombi, endothelial injury are potential causes. We definitely need more research and data, especially about screening strategies, both for the vaccine-related cardiovascular as well as COVID-19-related cardiovascular events, and for us to follow on the long haul or the past post-acute COVID sequelae. And I think there are large-scale studies currently being conducted for population-based screening with biomarkers as well as with imaging and clinical outcomes. Thank you for your attention, and thank you for providing me the opportunity to cover this topic today. I'd be happy to take questions.
Excellent. Thank you so much. Very important information. Let's see, we had one person from the VA raise their hand. Dr. Hundley, do you want to start? You had raised your hand here. Go ahead.
Sure, Biykem, thank you so much for that outstanding presentation. Wanted to just make one sort of comment and then a question. I noticed with doing cardiovascular magnetic resonance over the last 5 or 6 years, we've switched from primarily performing those procedures at 1.5 Tesla to now 3 Tesla. And as someone, doing many of these a day, and I was sharing some stories together with John Grizzard and some of our other faculty, at 3 Tesla, you have a lot more capability to visualize abnormalities in the heart. The way I think about it, it's kind of like the high sensitivity troponin of imaging. And I wonder, I liked the point that you made about controls, but it might be interesting as we move forward to just start to report, well, how many patients without COVID, or that might just be athletes or what have you, that will have abnormalities on MR that maybe we're ascribing those to, inflammation or injury, but perhaps maybe there's a low level of inflammation or injury in many conditions. The second point, and then the question, if we have a patient and they experienced COVID-related myocarditis and they had MRI findings and we rescan them at 6 months and there are some minor abnormalities, but a reduction in the magnitude over time, are we good with letting them go back to their athletic pursuits?
So I'm going to tackle the second question first. Don't know the answer, right? So we need the data. And so far, looking at that return to play strategy that was published, looking at the incidence rates, they employed a similar strategy of when things are better, you can go back to sports and have reported no adverse outcomes. I would state, I would do truly a multidisciplinary discussion on the findings because as we see with every single case, and not related to COVID, with any cardiomyopathy, the amount of risk burden ranges from whether the EF is low normal, whether the ventricle is a little bit dilated, whether we see the late gadolinium in certain patchy distribution, whether it's getting better. As to when you say getting better, I would look at the totality in a holistic manner of everything getting better and everything demonstrating a resolution, and maybe using the concomitant biomarkers to show that the inflammation and injury is over, and maybe we're dealing with a little bit of the fibrosis that you're detecting in MR. So the story, rather than one variable, is, I think, as critical in these approaches for individualization of therapies of, yes, you can go back to work, to play, or you can do this. I know we need algorithms at the population level as well as at age, with the academies and societies, but I, on a clinician bedside perspective, do individualize. So I would use your framework of what does that normal mean compared to the background, right? So back to your first question, I fully agree with you. As you know, we had numerous discussions on what is abnormal in the context of the evolving methodology with CMR as the sensitivity to detect anything abnormal increases. How about for a thick ventricle in an athlete? How about in an individual who's older, who is potentially with a little bit of more fibrosis in their whole body and or myocardium? What does let's say a little bit of a change in the T1 mean in that individual compared to the remainder of the population? I think we need to have the normals defined in numerous phenotypes. I fully agree with you. As the methodology changes, like we do with the troponin, you need your 99th percentile for your population. I can tell you our 99th percentiles differ even for cardiac troponin in the populations we're studying. So it's very similar to that. My answer to your question of, I like actually CDC's approach of looking for both of them, meaning cardiac troponin elevation as well as CMR abnormality concomitantly. If it's no symptoms, no biomarker abnormality, and just one of these variables that is found on a CMR, I'm not so sure without having the control groups, one can ascertain that this is abnormal. I would definitely consult you and ask, Greg, how abnormal does this MRI look compared to all the other normals you've seen? And I think we need to go with that approach rather than just using arbitrary single imaging criteria, especially where the centers have not developed that familiarity and expertise in interpretation of cardiac MRI, because this could create a flurry of abnormalities that could create a huge population of subclinical abnormality that we would not know what to do with. So far, these are not associated with adverse clinical outcomes.
Right. Sounds like an on my mind.
Oh, yes, I do totally agree with you. But we definitely need the controls, and I agree with alerting the public against this. And that's why I like us to use criteria that are much more specific in these population-based approaches.
Thank you. I know there's some other questions. Thank you so much.
Sure.
Thank you all very much. We have one person from the VA. I'm going to unmute, see if they wish to ask their question. Somebody raised their hand. Not sure if that was by mistake.
I saw one question in the chat. If a person had tachycardia after the first dose, do you recommend they receive the second dose? Tachycardia by itself is not diagnostic for myocarditis. Actually, in most of the case reports, I actually have that in my publication. The heart rate was not, that elevated. The heart rate elevation could be due to the constitutional symptoms, the fever, the myalgia, and our body's response. But if it is a persistent tachycardia, that may require an evaluation by a cardiologist just to put things in perspective. So the first day, if one feels febrile, myalgias, a little bit of heart rate, dehydration, all of those inflammatory, I'm not so sure I would consider tachycardia by itself as diagnostic for myocarditis.
Excellent. I wasn't able to get the person from the VA on, so they may have just accidentally. I don't see any other questions, but thank you so much for the presentation today. Really enlightening. Dr. Syme, Dr. Hundley, any closing comments?
Hi, Patricia Syme. Thank you very much for such an evidence-based presentation. Really enjoyed it and appreciate spending the time here with us on virtual Zoom at VCU.
Thank you, Dr. Syme, Dr. Hundley, and it was a pleasure to be with all of you and to be able to go over this. And thank you, Dr. Bergman, for your coordination.
Biykem, thank you so much. We really just super. And thanks for all you're doing really in the world of cardiovascular medicine and heart failure as well. Thank you.
Thank you.
Thank you all. This concludes the Internal Medicine Grand Rounds. The CME code is available in the chat as well as the QR code. Hope you all have a great day. And don't forget about the chili cook-off on Saturday, 4 p.m. All right. Thank you all. Take care.
Heart healthy, of course.
Yes.